Welcome to Chronic Pain Facts, What You Need to Know, Part 2. I hope Part 1 was very helpful for you, and I hope as well that Part 2 will also empower you to make better decisions. So in Part 1, we covered medications, and now in Part 2, we're covering all the rest. So the whole pain management thing includes these 4 topics: the pain medications, pain treatments, procedures, pain and medical imaging, and pain and surgery. And in Part 1, it was all pain medications. So right now, we're going to talk about pain treatments and procedures. So steroid injections, they are very, very commonly done. I'm very shocked actually at how often a patient in the clinic will tell me that they went to see the orthopedist and they recommended a corticosteroid injection and right away just did it. And I asked the patient, I said, well, were you informed of the risks and the benefits? And they kind of look at me funny like, what? And so nobody's told these things. It's just advised. Now, they might be handed a piece of paper, they might not. But these are the side effects. And these injections are very common in your shoulders, elbows, knees, hips, SI joints, and the spine. The risks: death of nearby bone, osteonecrosis, joint infection, nerve damage, deterioration of cartilage, tendon weakening or rupture, and thinning of nearby bone or osteoporosis. Now, these are things that a person needs to be aware of before they agree to something. And so now, if there are risks, but if you're in a lot of pain and you think it's going to help you, let's see the benefits. Well, if it's used for low back pain and sciatica, pain relief, if it occurs, tends to be temporary. It's not advised for long-term use. And this was a National Institutes of Health funded randomized controlled trial, and it showed long-term outcomes were actually worse among those who received the injections compared with those who did not. I don't think anybody wants to be worse off and risk those side effects. When it comes to knee osteoarthritis, this study shows that 2 years of the injections compared with saline or salt water, the injections of the corticosteroid actually resulted in significantly greater cartilage volume loss and no significant difference in knee pain. Now, I know you may know somebody who said, oh, I got an injection and I felt so much better. Well, that's not the norm. Trust me. I see lots of people who get these injections, and more often than not, I hear it didn't help at all. So these findings do not support this treatment for patients who have symptoms with knee OA. And I say who have symptoms because oftentimes people will have osteoarthritis or OA and they don't have any symptoms. Let's look at pain and medical imaging. MRIs often will identify little tears in the meniscus, and this is assumed that this is the cause of knee pain when someone's complaining of knee pain. Well, in this study, researchers scanned almost 1,000 people. Some of them had knee pain, some of them didn't. The tears in the meniscus were just as common in those who did not have pain as those who did have pain. So what does this mean? It might sound confusing, but what it means is if tons of people are walking around out there who have meniscus tears and they don't have any knee pain, why are we assuming when someone does have knee pain, the cause is the meniscus tear? Because it seems like it can be there and not cause pain. And when you're trained like I am and you know that the knee is just a simple hinge joint stuck between the hip and the ankle with no place to go, you know that the hip and or the ankle can really be the culprit when it comes to knee pain. So maybe they do find a meniscus tear, but maybe their problem is their hip or their ankle, and they have surgery for the meniscus tear, and now they still have pain in their knee. Go figure. So here's a medical imaging study on rotator cuff tears. And I know rotator cuff tears of the shoulder are so commonly believed to be the cause of pain. Now, yes, often they can be, but look at this study. This kind of gets us thinking a little bit differently. This study looked at over 660 subjects, and 22% of them had full thickness tears, not even just partial tears, but full thickness tears. The interesting part is that only a third of them had symptoms. That means 2/3 of them did not have symptoms. Now, the tears got more and more prevalent as the people got older in this study. So when you look at the numbers here, people in their 20s, 30s, and 40s pretty much didn't have any tears. Once they hit the 50s, they started to have tears, and then 60s, 70s, 80s, there was a higher prevalence. But more didn't have symptoms, the light gray bar, than did have symptoms, the dark gray part of the bar. So even in their 80s, more of them did not have symptoms, even though they had these tears. Looking at medical imaging in the neck, looking at the discs specifically, abnormal findings in subjects that are asymptomatic. That means they don't have any symptoms. Of over 1,200 subjects with no symptoms, and they were only in their 20s. 73% of them were men, 78% of them were women, so pretty good study. They had bulging discs in the cervical spine. 73% of the men, 78% of the women. Bulging discs. No symptoms, none. Here's talking about imaging of discs and degenerative disc disease. 20 to 25% of people who have no back pain show a herniated disc on imaging. 60% of people who have no back pain show degenerative changes in their spine. So don't hear what I'm not saying. I'm not saying that these things can't cause pain. What I am saying is I don't think it should be the definitive reason for a diagnosis just by looking at an imaging report. Because what shows up on imaging may have nothing to do with the reason the person has pain. Here's another study. This doctor in the Cleveland Clinic ordered MRI for patients who did have back pain or leg pain. 13% of them showed that the herniated discs got worse in 6 weeks, and 15% of them, the herniations actually resolved. They were no longer visible. The interesting part, there was no relationship between the pain and whether or not the discs worsened or the discs resolved. No relationship. Some of them who had worsening pain showed that herniated discs had actually disappeared. Some of them who had improved pain showed that the herniations had actually gotten larger. So again, we're assuming what we see on imaging is the reason for the pain, and we should not be making those assumptions because the scientific data doesn't support this. There is a huge lack of correlation between imaging results and low back pain. It's becoming well known. Chronic low back pain is blamed on degenerative changes, yet it's not supported in the literature. In the long run, this is another study, patients who receive an MRI don't end up in any better results with their back pain. So I often will tell people, well, the only real reason to get an MRI is if you want surgery, because that's what they're looking for. They're looking for a reason to perform surgery. Now, I can count on the fingers of one hand the number of times I've recommended somebody, you need to go get an MRI, you need to go see a neurosurgeon. Okay, so sometimes it's absolutely necessary, but I've been doing this for over 25 years, and that's the only number of times I've said that. So I don't think it's as common as we believe it is. So X-rays, CAT scans, MRIs consistently show bulging or herniated discs, subluxations, scoliosis, osteoarthritis, pinched nerves, that this all appears unrelated to whether or not someone experiences chronic pain. So these things can show up on people who have no symptoms as well as people who do. And so very often what I find is there's many other reasons people have pain, and we will be going into those shortly. So now let's look at surgery. Spinal surgery specifically. patients who have pain, patients with pain from herniated discs from 13 spine clinics in 11 states were followed. So this was a pretty good sized study. Patients who did not have surgery had physical therapy, cognitive behavioral therapy, and some took anti-inflammatory drugs. But we already know those really aren't all that effective, right? 40% of those assigned to have surgery did not, because they improved while they were waiting. The data shows that herniations can resolve usually within 6 months to a year. Now, I know that's a long time to be in pain if that's what's causing the pain, but I want to tell you there's a beautiful method called the McKenzie method that's very effective and can be effective in like 15 minutes at reducing pain. I had one young man who was in so much pain he could barely move, he couldn't sit, he was like this because he had so much pain. And within a week, we got the pain out of the leg. Within 2 weeks, we got the pain out of the back. Within 3 weeks, we had him lifting weights again. So, and that was using McKenzie. So, and I'm going to be providing resources here, but I want you to know that young man was advised for surgery and he was adamantly against surgery. And it only took us 3 weeks to get his life back without surgery. So, and the data shows that doing nothing, herniations can resolve. This study, after 3 to 6 months, patients in both groups reported significant improvement, and after 2 years, both groups reported major improvement in pain levels. So the surgery did help these people, but the people who didn't have surgery had the same result. So those who opted not to have the surgery weren't any worse off, right? When you compare spinal fusion surgery with rehabilitation, and spinal fusion surgery is, I've had neurosurgeons tell me they don't recommend spinal fusion. So in this particular study, no difference in outcomes for patients who had spinal fusion surgery versus patients who underwent intense rehab. And that means they had rehab that was effective, that actually did something, that worked. I know a lot of people who say, you know, oh, the therapy didn't work, but I'll tell you, I see a lot of patients who don't commit to the therapy. They're not consistent with coming to therapy, and they're not compliant with doing their home program. So those people are not going to see results. So in this particular study, complications, financial costs of surgery obviously are huge. There's no complications and little expense from rehabilitation. So I would say doing rehab would be a good idea. When it comes to knee surgery, this was a 2013 study, and it looked at the meniscus tears, compared those who had surgery versus those who didn't. Now, the patients were randomized to receive either arthroscopic partial meniscectomy, which means the removing the torn part of the structure, followed by PT, or a 6-week PT program. And this is what they found. The results were about the same for both groups. The researchers concluded the difference between the two groups was neither clinically important nor statistically significant. So why don't we try therapy before surgery? So here's a 2013 study. Every year there are hundreds of thousands of knee surgeries performed in the US, and most of these surgeries are useless, no better than sham surgery. And what this study did is they had people believe they had surgery. They got permission from family members to do this within this study. So these people actually were anesthetized or whatever it is that they were doing, local anesthetics, and they actually thought they underwent surgery on their knee. These people did just as well as those who did have surgery. So this study shows estimated 700,000 unnecessary arthroscopic knee surgeries are performed every year in the US at a cost of close to $4 billion. And I could go into this. I've spoken on this topic many, many times. Again, this is supposed to be a chronic pain facts presentation, so we're not going into huge, lengthy detail on each one of these things. But please know, there are so often that surgery is being performed that it could have been prevented. And I took a course from a woman from New Zealand, and she said that what we need to do is lay across our patients and say, no, doctor, let me have them first. And oftentimes I see people post-surgical. I didn't get the chance to see them before surgery. And it upsets me because I think I don't know, maybe we had a chance of preventing the need for surgery at all. Maybe the person didn't need surgery. And oftentimes, these people present with issues and things that I know the surgery didn't resolve. So, and it needs to be addressed. So why all the failure treating chronic pain? Now we're going to get to the good part. What's missing? The core issue is not addressed. I actually have a video titled "The #1 reason your pain isn't going away and what you can do about it." And the #1 reason your pain isn't going away is because the core issue is not being addressed. And that's not a play on words. It's not a joke. It's because if you have shoulder pain and your problem is because your sacrum is torqued and it's pulling on that lat dorsi, which is depressing the head of the humeral bone, which is making the shoulder be out of alignment every time you use it, so the structures are getting trashed and injured and inflamed and annoyed, until you fix that sacral torsion, nothing's going to help that shoulder get better. So that's what I mean by the core issue is not addressed. We focus on a body part. We just put a microscope right up to that body part, and we x-ray it, we image it, we inject it, we heat it, we ice it, we exercise it, we stretch it, we massage it, but we don't look at the whole body. That's the problem. We treat the cause of the pain. We treat the symptoms. We don't treat the cause. What works for pain is treating the cause, finding the cause, locating the culprit, and not beating up the victim. So core issues of pain are often multifactorial. Nutrition plays a huge role in chronic pain. There's a huge role of food creating chronic inflammatory conditions in the body. And I have training on that if you want more information on that. I can't go deep into each and every one of these, but I will make sure you understand how important they are. Lifestyle is important. If somebody's sitting constantly at their job and at home, those major power muscles in the back of the hip are not working. So the back's not going to be happy. The hips aren't going to be happy. The knees aren't going to be happy. Okay? Even the neck. There's something called hyperalgesia, where if you have an injury or a trauma or a surgery and those pain cells, those silent or sleeping nociceptors get awakened and they don't go back to sleep. That's hyperalgesia. You know, a touch is extremely painful. That's hyperalgesia. Something can be done for those. The pain patterns, faulty thoughts. We're going to go into these in a little bit of detail. So, nutrition. Fat consumption negatively impacts circulation. Anything that negatively impacts circulation can lead to chronic pain. You have arteries to your spine. Lumbar artery disease, which was coined by Dr. Leena Koppila from Finland, will tell you, all of her studies for decades, published works, will tell you that decreased circulation to the lumbar arteries will lead to degenerative disc disease, will lead to sciatic pain, will lead to deep hip pain and muscle pain and back pain. So circulation is important, and fat consumption negatively impacts circulation. We can't worry just about our heart and just about our brain. We have miles of blood vessels in our body, and that blood supply has to get to every single cell, every joint, every muscle, every bone, every area of the body. So circulation is important. Arachidonic acid promotes inflammation. And there's very high levels of arachidonic acid in animal foods, moderate amounts in baked goods, very little to no arachidonic acid in plants. So a diet that's very high in animal foods and very low in plant foods is going to promote chronic inflammation in the body. Excess weight also promotes inflammation because fat cells will increase the inflammatory conditions in the body. So it's important that you know these things so that you can make these changes. I've seen people reduce pain in their body very quickly, in less than a week, just by making dietary changes. It works. So please know this and get more information. Learn from an expert. Get solid guidance in order to make these changes, and you will see benefit. So improve the nutrition. Use dietary excellence. It's taught by Wellness Forum Health. I also teach it in my business, Have Lifelong Well-Being. It's a low-fat, whole food, plant-based diet, and it works. Lifestyle. As I said, if somebody's very sedentary, if they're sitting on those muscles, they stop working, they weaken, they atrophy. Your body is designed to move. Your body needs to be strong and mobile in order to be pain-free. Smoking, of course, radically affects oxygen to every cell in the body. So it does affect circulation. It does affect nutrition being provided. It affects so many things. Alcohol consumption. Any more than 1 to 2 drinks a week will negatively impact health in multiple levels, including increased risks of cancer. So red wine is not good for you. It is not your friend. That is false information. The studies that talked about resveratrol in red wine were actually recanted because the publisher of the research admitted to lying. So if you Google that, you'll find that out. But know that alcohol is never healthy for you. And I'm not saying you need to be a teetotaler. I'm simply saying you need to know the facts. More than 1 to 2 drinks a week will adversely affect health. And that is part of a poor lifestyle. And then poor stress management. We all have stress. Some of us have more than others. Some of us are dealing with being caregivers and all kinds of lots and lots of overwhelming responsibilities in our lives. But everyone has stress. And if it's not managed properly, if we are not getting proper counseling, proper help, then that stress can really radically increase pain. It will also increase your respiratory rate, which addresses your vagus nerve, which puts you into a state of anxiety. So these things are important to address. So an exercise program, absolutely, if you're sedentary, but it has to be the right exercise program. I created Move Without Pain private club to help people with just such that problem. Smoking cessation, very, very important. Limiting alcohol consumption, as I said, to 1 or 2 drinks a week, and then stress management, all very important to address lifestyle as part of addressing positively chronic pain. Hyperalgesia. Nociceptors are pain cells, and they respond abnormally to normal stimulation when they have been triggered. Now, oftentimes when someone gets injured, those sleeping or silent nociceptors who wake up with that trauma or that injury go back to sleep. That's the normal thing that's supposed to happen, but sometimes they don't. And so now you get what's called hyperalgesia. There are ways to address this. There are ways to retrain these nerve cells and resolve hyperalgesia. You just need to find someone who knows how. Reactive pain, pain patterns. Say you got up out of bed one morning and you experienced severe back pain. Well, now the next morning when you go to wake up, you open your eyes and your brain remembers yesterday when you got up, you had this horrific pain in your back. So now your brain is telling you, oh, when we get up, we're going to have back pain again. It becomes a pain pattern. The brain actually tells you to experience the pain. I'm not saying the pain is in your head. You're experiencing real pain, but it becomes this reactive pain. This can be retrained as well. You can retrain your brain and your body. You can change pain patterns and resolve them. It can be done. There's a wonderful book called Life After Pain by Dr. Jonathan Kuttner, Kuttner. He addresses these topics in great detail, and it's very, very helpful information. Thought patterns, faulty thoughts, emotions, and beliefs. Dr. John Sarno has written several books. He had a beautiful program. I don't know if the program is still ongoing because he passed away recently, I think just a couple of years ago at the age of 93, maybe 95. But his work is foundational in addressing this, where people have this chronic pain, this serious pain that's not resolving. No one can make head or tails of it. And what's found out is that this pain is being produced in the body. It's real pain, but it's being produced in the body as a protective mechanism because of some very, very traumatic emotion that the brain and the body does not want to address or acknowledge. And many people, I think it was 90-something% of the people, were able to resolve their pain just by knowing this fact, because they realized, oh my goodness, that's right. I'm really angry that my husband died, or they realized they had some deep emotional thing they hadn't acknowledged or resolved, And that ended up creating this chronic pain in their body, real pain, but it was caused by thoughts, emotions, or beliefs. And just knowing that was able to help these people. So be aware that that could be something. And Dr. Jonathan Kuttner actually quotes some of Dr. John Sarno's work in his book. You can improve your thought patterns. You can, I would highly recommend empathic therapy. That's what Dr. Peter Breggin practices and many others. Cognitive behavioral therapy is also known to be extremely effective at helping people to address these issues. Biomechanics, biomechanical asymmetry. I know that's a mouthful. SI dysfunction, your sacroiliac joint, which is where your hip bone meets your sacrum, that upside down triangle that's at the bottom of your spine with the point being a tailbone. You could have what's called a sacral torsion. You could have things go on, maybe a little fender bender when your foot was on the brake and you got rear-ended when you were sitting at a red light. Even if it's a small impact, it can create a torsion in your sacrum. It can create this kind of skewed pelvis, which can create pain. There are techniques to address these things that are very effective. You can correct the biomechanics with manual techniques, and I'm going to list some of my favorite manual techniques so that you'll know what to ask for when you're seeking professional help in your area. Neurofascial inefficiency. Again, this is a big mouthful. This means that connective tissue in your body has become dehydrated. It's become restricted. It's become compressed. And what this does is this alters the symmetry of your body. This changes the actual curves of the spine. It can increase the curve in the low back to the point where there's so much stress on the pelvis and the shoulder girdle that you end up with chronic pain. It can decrease a curve somewhere and create pain. So it's very important that this system is addressed, this neurofascial system. And it's very easy to positively impact and restore neurofascial efficiency with the MELT method. And you can think of it this way. This system is meant to communicate so that your brain can direct your movement. And if there's poor communication, it radically impacts your brain's ability to direct movement. So you have a thought, I'm going to go over there and pick up that basket, but the brain can't direct you well because it's not hearing from parts of the body. It doesn't know where certain parts are, so it's not going to direct efficiently. And that can lead to chronic pain and moving with pain. And this can be resolved sometimes in one session. The MELT method is wonderful, and you will see an immediate benefit the first time you perform it. Three-planar function. Three-planar dysfunction will lead to decreased mobility and or stability in one or more planes of motion. And this is so impactful on your body's ability to move, your body's ability to perform the daily tasks of life. If you have pain going up and down stairs, it could be your hips are lacking something in transverse plane. If you have pain with walking, it could be your ankle maybe lacking something in the sagittal plane. You need to ensure that your body is functioning in all three planes of motion and doing it well. You can reestablish that three-plane function using the Move Without Pain training. And I'm going to talk about these things in a moment. Neural imbalance. If you have a difference in strength or range of motion in opposite sides of the body, that can radically impact how you perform tasks. If you notice that you can rotate really well to the right, but you can't rotate to the left so hot or it creates pain, know that this imbalance is forcing your body to compromise, to compensate for every movement you do throughout the day. And when you compensate, that's when those areas that are compensating start to complain, start to become injured. The structures become injured, they become damaged, and things happen that you do not want to happen. So you want to resolve neural imbalance, and my favorite method for that is called total motion release. So what works for pain? Because we talked about core issues being multifactorial, right? Nutrition, lifestyle, hyperalgesia, this whole long list. We just talked about these things, I know briefly, but hopefully you have enough information now to empower you to know what works for pain. Your physical therapist, your massage therapist, your chiropractor, your osteopath, your body worker, your athletic trainer must understand how your body performs and reacts throughout normal motion and functional living. Remember, you want to be an informed consumer because it means you will make better choices and have improved outcomes. So here's the resources. Diet, exercise, and weight loss can dramatically reduce or eliminate pain. I've seen it happen over and over and over again. I teach a Nourish Away pain course at the local community college, Hudson Valley Community College, twice a year. I serve a 4-course meal. I provide recipes, a written manual, and these people come in the second class telling me they cannot believe how much better they feel. It works. So you want to take the Nourish Away Pain for Life nutrition class series, and that is provided on my website. Or you can go to Wellness Forum Health and you can become a member there and learn lots of great things. There are other resources. PCRM.com also teaches lots of great things about diet and how to change things. They have, I believe, a 21-day jumpstart. Dr. John McDougall also has a beautiful resource on his website with, I think, a 10-day beginner plan. So there are lots of great resources for you, but you want to be sure that the person that you're listening to has a long, very, very dependable track record of being successful at helping people. That's the question to ask. The right diet can prevent, stop, even reverse disease, and there's no stage at which diet cannot make things better. Diet's inexpensive, effective, with no negative side effects. You are in control of your health. So, accessing quality care for chronic pain, I mentioned earlier, manually trained professionals can really help you. You want someone trained in muscle energy technique, or trained in counter strain, or Mulligan's mobilization with movement, or the McKenzie program. You want to be sure these people are trained in these. Now, they may not be a physical therapist. They might be a massage therapist. A lot of the manual coursework I attended was heavily attended by massage therapists. Some of them are very gifted at manual work. I believe McKenzie is only for physical therapists, though. Maybe occupational therapists, too. I'm not sure about OTs, but I know PTs. But look for somebody who's trained in these. Ask questions when you're looking for help. Also trained in self-care concepts, the Move Without Pain. That training is available online. I teach that to people all over the world via online video. I also have a Move Without Pain private club that you may be interested in. The MELT method, you can go to, I've got the websites in just a moment, and that will help with that neurofascial efficiency in pain. And then total motion release is for that imbalance side to side. Anyone trained in those is going to be able to help you. So here's the website for the online training, and it's movewithnopain.com. And it doesn't just treat the symptoms, it resolves the cause of the pain, because life is meant to be enjoyed, not endured. So I also have a private club. It has weekly classes that are online that you can watch 24/7, and a new class is posted each and every week. There's a geek corner where I do a tip of the week. There's a Q&A where your questions can be answered. And there's powerful truths that are taught, like your hips are your power source and your stabilizers. You learn what eccentric motion is. You learn lots of great things in the club. So if you want to find somebody trained in total motion release, this is the website. If you want to find somebody in your area that's trained in the MELT method, this is the website. There's also people trained in applied functional science, which is what my Move Without Pain training is based on, my own certification in applied functional science. I am not an instructor with the Gray Institute, and Move Without Pain is not a program that they've created. If you want to find somebody in your local area, contact them, and they'll tell you who is certified in applied functional science in your area, and they'll be able to help you. There's also a free website, this F2Pacademy.com, where there's all kinds of free dynamic movement training and a program on the website, and it can help people of all abilities. So remember, you want to be an informed healthcare consumer because that means you will make better choices and have improved outcomes. This is my contact information. These are the websites, and please, please know that you can radically impact chronic pain if that's what you are experiencing or someone you know or care about is. Just try these things, research these things. Don't give up hope. Someone has an answer, and what you've learned here just may be it. So what's your goal? You can achieve pain-free movement and ideal health to look and feel better than good. I want you to have lifelong well-being.